HOPE study. HOPE stands for Health Outcomes of Young People in Education. This is a study that's funded by the NIHR, the National Institute for Health and Care Research, and it's a collaboration between UCL and the University of Cambridge. So for those of you that have been to ECHILD seminars before, you'll know what to do and how to stay in touch. You can join some of these mailing lists with ECHILD or the ADR UK, and you can also keep an eye on the website for future events. During this seminar, we will be able to take questions by you typing questions into the Q&A box on your bar at the bottom, so not into the chat box. So I'm just going to, for those of you that are not so familiar with the ECHILD database, I'll give you a brief overview. ECHILD contains de-identified data from coded hospital data and from state schools in the National Pupil Database. These data have been linked together for all children and young people in England born from the late 1980s until 2022, and it includes around 20 million individuals at the moment. The data are kept in a secure environment, and they're held at the Office for National Statistics. There's no opportunity for re-identification or for being able to deduce who's in those data. So the HOPE study. So the HOPE study is a programme of research that's coming towards the end, and what you're going to hear about today is how we answered 3 questions shown around the circle in the middle here. First of all, I'll just say something about what do we mean by special educational needs provision, or SEN provision. This is adjustments for children who receive provision for special educational needs in the form of additional help in school for their learning needs to enable them to participate in school and achieve their potential. Roughly 1 in 3 of all children who attend state school will have received some form of SEN provision by the age of 16. So this talk that you're going to have today presents answers to 3 of the 4 questions that we asked in the HOPE study. This is based on the quantitative analyses of the ECHILD database, which you see in the centre. There's a 4th question, which was using qualitative methods, which was about what are the experiences of SEN provision from the perspectives of young people, parent carers and professionals. And this has been very important to inform our understanding of the data and what we were missing in the data, but you're not going to hear about that today. So the 3 questions that will be addressed, I'm going to hand over to Ayana, who's going to show you for the question 1, do outcomes vary compared to peers for children with different health phenotypes? And she'll explain why we started with that orange box, which is about defining health phenotypes. So over to you, Ayana.
Okay. Thank you. Yeah, okay. Great. So as Ruth mentioned, the aim of the first question is to identify a range of health conditions in children that increase their likelihood of requiring additional support in school and compare the health and education outcomes of these affected children to their peers. So as we know, children with special educational needs face greater difficulty in engaging in and accessing education compared to their peers. However, there is no indicator in the National Pupil Database, which is the educational data included in ECHILD, for which children may need SEN provision. All we have is an indicator of who receives this additional educational support. And this is an issue because we know from, for example, our qualitative work that assignment to SEN provision is subject to multiple tiers of influence from the child, the parent, school, and area level factors, meaning that the pupils who are recorded to have SEN provision are not fully representative of the whole population of pupils who may need SEN provision. So to identify this population of need, we used hospital data to identify health conditions known to be predictive of additional learning needs, to devise groups of, we call them health phenotypes, that can be used to proxy the likely need for SEN provision. And these are recorded before and independently of school-based assessments and assignment of SEN provision. So we derived three main groups of phenotypes, which include neurodisability, which is our highest risk and most severely affected group of children, major congenital anomalies, and gestational age groups, which stratify the whole population from extremely preterm to 40 weeks of gestational age. Today, we will be focusing on neurodisability, which describes a group of long-term health conditions that affect the nervous system and the brain and result in day-to-day functional limitations. As you'll see, it's quite a broad and varied group of conditions, but together they affect almost 4% of children in England by the end of primary school. Okay. So to decide which conditions were included in our neurodisability group, we developed an algorithm for detecting ICD-10 clinical codes from hospital records that identified chronic conditions that impact the brain and the nervous system and cause these impairments to day-to-day life. This was a clinical approach, it was a rules-based approach using both a scoping review of the existing literature and previously published code lists. But it also underwent multiple reviews from expert clinicians. And then we applied this list of clinical codes to a national birth cohort of children born in England from 2002 to 2008 to identify the population of children with and without these neurodisabilities. And we followed them from birth through their subsequent hospital admissions, to school entry at age 4, all the way to the end of primary school at age 11. So we could then look at health outcomes such as mortality, hospital admissions, and education outcomes across all of these primary school years. So as I mentioned, the prevalence of neurodisability as a group of conditions is just under 4% in our cohort. But here we show the cumulative incidence of neurodisability conditions by age at first diagnosis. I just wanted to use this to highlight the types of conditions we include in our phenotype. So these are neurodevelopmental conditions such as autism, cerebral palsy, epilepsy, motor function impairment, and perinatal conditions. And we've highlighted the most common conditions in yellow. As you can see, there is a lot of variation in the incidence of these conditions, variation in the age at first diagnosis, and as we will get onto, variation between these subgroups in terms of health and education outcomes as well. Okay, so for the first outcome, we look at a health outcome, which is the rate of hospital admissions for children with neurodisability. So as we would expect, children with neurodisability, represented by the yellow line, have substantially higher rates of both planned and unplanned hospital admissions. It's hard to tell from the scale because the scales are not the same, but admission rates for children with neurodisability were nearly 7 times higher for planned admissions and 5 times higher for unplanned admissions compared to their peers across primary school. So in addition to experiencing overall high rates of planned admissions across school, the difference in admissions rates between children with neurodisability and children without neurodisability remain greater in the planned admissions compared to unplanned admissions. And this could be because children with neurodisabilities have more medical visits that are routinely planned in advance to manage more complex health conditions, whereas unplanned last-minute emergency GP appointments are common for children, still more common for children with neurodisability, but probably not as uncommon for healthy or unaffected children. Okay, this is the first and very important educational outcome, which is a proportion of the population who are recorded to receive SEN provision. So in England, we have two forms of SEN provision that are offered. SEN support, which is a less intensive form of support, and an education and healthcare plan, which is a more intensive form of SEN provision for more complex needs, and it's provided by the local authority. So the bars on the left of this graph represent the proportion of children to ever receive either form of support at any point during school. And we can see that over 70% of this neurodisability group have a form of support recorded at some point during school. But the largest difference lies in the proportion of children with an EHCP, which is highlighted with the red box, where 38% of children with a neurodisability have an EHCP recorded ever in school, compared to 2.4% of their peers. So the main takeaways here is that using hospital records only, we can capture this high needs group who are more likely to require an intensive form of support of SEN provision compared to their peers in primary school, making the phenotype a valuable tool for proxying which children may have these additional learning needs that cannot be picked up in education data. So next, we described rates of school absences for children with and without neurodisability. Again, as expected, children with neurodisability were more likely to be absent from school. So between year 1 and year 6, children with neurodisability have had an overall absence rate of 6.5% compared to 4.2% in peers, and a health-related absence rate of 4.8% compared to 2.9% in peers. They were also more likely to be persistently absent, shown in the bottom left graph, where persistent absence is recorded if a pupil misses more than 10% of total school sessions, which is around 7 days of school per term. So almost 20% of children with neurodisability were persistently absent between year 1 and year 6, compared to less than 10% of their peers. Okay, so the final education outcome we looked at is the proportion of children achieving expected levels of attainment under the national curriculum. So during reception, when children are aged 4 to 5, they're assessed on whether they've reached a good level of development, or the GLD, which is basically just an indicator of school readiness and incorporates literacy skills, math skills, but also physical development and creativity. As we can see in the red, circled in the red, over 70% of children with neurodisability do not meet this expectation at the end of reception, compared to 42% of peers. Now, if we look at the same cohort in Key Stage 1, which is year 2, ages 6 to 7, we see a similar pattern. Children with neurodisabilities are more likely to fail and fall below nationally expected levels in both English and maths. In these graphs, the red bar represents the total proportion of children who did not meet expected levels, where the lighter red section shows children who took the assessment, who sat the assessment, but did not pass, while the dark red section represents those who were not assessed at all despite being in school at the time. And by Key Stage 2, we notice a shift. So while overall non-achievement rates stay quite stable between Key Stage 1 and Key Stage 2, children with neurodisability still underperform compared to their peers. The proportion of those not sitting the assessments at all increases quite dramatically, shown by the increased dark red section in the Key Stage 2 graphs. So over time, the reason for non-achievement in primary school attainment changes from initially not passing the test to later being not included in testing under the national curriculum, despite still being enrolled in school. Okay, so now if we look at the same Key Stage 2 results, but broken down by neurodisability subtype, we see significant variation in attainment outcomes within this group. So children with Down syndrome face the greatest challenges in education, with an achievement rate of just over 1%. This example is Key Stage 2 English. But in contrast, children with perinatal conditions, which we can see on the far right, have the best outcomes and perform most closely to their unaffected peers. And we see a similar pattern between the subgroups in both hospital admissions and absences as well. Okay, so to summarise what we have learnt from the first question, the first part of HOPE, is that we can use health phenotypes derived from hospital records to identify children who are likely to need SEN provision. And this is important because there is no indicator of this in school records. So the children with these health conditions, as we demonstrated, have worse health and education outcomes, although these vary greatly by subgroup. These phenotypes can also be used by healthcare and education sectors to work together to identify this population of need and plan resource and service provision accordingly. It can also be used in the second and third part of our study, which tries to answer what is the variation in provision and what is the impact of SEN provision, which Vincent will now take you through.
Hi, my name is Vincent. Thank you for coming. I'm here to present on behalf of Work Package 2 and 3. So Work Package 2 here is led by Dr. Kate Lewis, and the question for this investigates the factors contributing to the variation in SEN provision. So the first piece of work I'd like to introduce demonstrates political factors which impact temporal changes in SEN provision. This is currently published in the International Journal of Population Data Science. So in this study, the population of interest consists of children with a recorded birth in HES between 2003 and 2013. The exposure and phenotypical comparison was also measured in HES and was a recorded major congenital anomaly. The outcome measured in NPD was recorded SEN support, EHCP, so an educational healthcare plan, or special school attendance during primary school. Overall, there were 5.2 million children included in the analysis, of whom nearly 200,000 had a hospital-recorded major congenital anomaly. So on the left here, we can see that the paper estimates that 25% of children without any MCA recording had any form of SEN provision during their primary education. In this figure over here, children in black represent SEN support in a mainstream school. Children who are in blue represents EHCP in a mainstream setting, and children who are red represent special school attendees. This 25% number is a comparison to 40% of children who had SEN recorded when any MCA was recorded in hospital data. The proportion varied among MCA groups, with 91% of children with a chromosomal MCA having SEN recorded compared to 52% of children who have a cardiac-related MCA instead. So on the right here, we can see changes in the proportion of SEN for both MCA and non-MCA groups post the Children's and Families Act of 2014. Between 2009 and 2013, SEN support in mainstream school was recorded for 24% of children who have a phenotypical marker for an MCA, whilst between 2014 to 2018, this dropped to 20%. And we also found similar trends for children who did not have a phenotypical recording for an MCA at all. The second piece of work we investigated was spatial variation in SEN provision by local authority. As many of you here may have heard or heard described, SEN provision might often be called a postcode lottery. To investigate this claim and to adjust for differential proportions of need for SEN geographically, this paper used a population of similar need for SEN provision. Those born between 34 to 36 weeks of gestation, what we call late preterm. The exposure and comparisons here were different local authorities in England, and the outcome was any SEN provision by the start of compulsory education represented as a proportion. Here we see a map of England divided by local authorities. with the maximum proportion of any SEN provision being nearly 30%, whilst the minimum being nearly 13%. However, these are quite the extremes. Whilst if we ordered the local authorities by proportion of SEN for children born prematurely, late prematurely, we see the difference in the 75th percentile and the 25th percentile only being about 4%. And furthermore, once we account for individual level factors such as chronic conditions, socioeconomic factors, racial ethnic background, first language, early years foundation, and school type, local authority differences kind of remain around 3% for SEN support versus no support at all at the start of compulsory education, and about 6% when comparing EHCPs to SEN support. So our third piece of work, which is currently ongoing, investigates temporal variability on SEN provision, where we look at social determinants which differ in the speed of getting any recorded SEN provision. Here, our population consists of children with a recorded cerebral palsy at birth. Our exposures and comparisons consist of multiple socio-demographic characteristics, and our outcome here is time to SEN, measured in days. To account for differential times when children start school, the ongoing work uses multiple cohorts which are staggered by entry to account for temporal heterogeneity. We're currently reviewing our preliminary results and hope to submit the full study within the next 2 months, and we'll be able to give you an update. Moving on. Our third question simply asks, what is the impact of SEN provision? Now, under the supervision of Professor Lorraine Dearden and Professor Bianca de Stabile, the aim here is to look at opportunities and challenges in using biostatistical and econometric methods for causal inference. The idea behind this work stream is that there are lots of evidence out there which demonstrates a negative association of having recorded SEN provision, but such work doesn't really take into consideration the need for SEN provision. This is because in the MPD, as we previously said, there is limited data for need for the whole population, and only a variable for why SEN was provided only in those who received or who were assigned SEN provision. To try and reduce these biases, we applied a target trial emulation framework approach to reduce biases when using observational data to answer policy-relevant questions. Examples of those questions might include understanding the impact of what would happen if we had a world where all children were to receive SEN provision versus a hypothetical world where no child receives SEN provision for outcomes such as hospitalizations or absences. So to understand the relationship between variables related to SEN provision can be confusing, but it is really important that we know the relationships between these variables. Traditionally, we might use a program such as Daggerty to draw a directed acyclic graph, but this can become very messy very quickly, particularly if a variable is related to everything else down the line. Therefore, we went back to the beginning and asked ourselves, what is a directed acyclic graph outside of epidemiology? Well, it's often defined as a conceptual representation of a series of activities. So we started off by drawing a timeline at the top and noting things which are recorded at each time point. For example, at birth, we have characteristics such as birth weight, gestational age, and in reception, ages 4 and 5. We might have events such as the EYFSP, Early Years Foundation Profile, and in year 6, we might have Key Stage 2 assessments. Here, in this DAG, we define our exposure as SEN provision at the start of compulsory education, year 1, age 5 or 6. And combining all this with contemporary DAG notation, such as a double arrow to denote that this variable is linked to everything down the line, we can draw our conceptual representation of a series of activities in a much simpler way. So up to now, I gave a theoretical idea of what's going on. In practice, this gets a bit more complicated. We wanted to look at the intention to treat effect of SEN provision at the start of compulsory education and outcomes during primary education. in the population of children who have cleft lip and palate. To account for the need for SEN, we use the target trial emulation framework to define a population of interest who have a homogeneous need for SEN provision, those with cleft lip and or palate, without other recorded major congenital anomalies. We aligned our observational data with a starter follow-up at the start of compulsory education with outcomes measured during primary school, such as unplanned hospital utilization and unauthorized absences. But before we can even get to any of this, we need to ask ourselves whether we could even compare the children who have recorded SEN provision to those who don't, as well as accounting for the fact that there are multiple levels of SEN provision, including none, SEN support, and an EHCP. So we went back to the basics of causal inference and looked at the pairwise comparisons of the categories of SEN, no provision, and an EHCP. So on the top right, we can see practically no overlap between no support and an EHCP. So it was deemed inappropriate to compare those children. On the bottom left, we can see a similar picture for EHCP versus SEN support. But on the bottom right, we can see a better, albeit not perfect, propensity overlap for those with no support versus those with SEN support. So we can only realistically compare these groups of children. So just a reminder of our question. In children with cleft lip and palate, what is the effect of SEN provision at the start of compulsory education on unplanned hospital utilization and unauthorized absences during primary education? To understand this question, we used multiple methods to strengthen our results. We started off with a crude analysis to understand the direction of confounding. We then moved to regression adjustment to estimate conditional effects of SEN. And then we moved to causal epidemiological and econometric methods, such as the inverse probability weighting or the parametric G formula, often called T-effects, and doubly robust augmented inverse probability weighting. What we found for unplanned hospital utilization was that the crude analysis demonstrated an increased rate of hospitalizations when comparing no SEN to SEN support. But when we used methods which accounted for confounding, we consistently found similar rates of unplanned hospital utilization when looking at the comparative effectiveness, again, of no SEN versus SEN support. And that's at the top. On the bottom graph, when we look at unauthorized absences, we found that our crude analysis, again, demonstrated an increased rate of unauthorized absences, that's anything to the right of that red line, when compared to no SEN provision. But when adjusting for confounding, we found evidence of reduced the similar rates of unauthorized absences with propensity score-based methods, such as inverse probability weighting and augmented inverse probability weighting, producing some protective effect of SEN support when compared to no provision. So we repeated our last study in a different population. In this case, children with recorded cerebral palsy. And unlike children with cleft lip and palate, we found comparability between no support and SEN support, as well as comparability between SEN support and an educational healthcare plan. But unfortunately, yet again, we cannot find comparability between no support and an EHCP. And with more comparable groups, we have a few more results. On the left, we are looking at children with recorded cerebral palsy. We find that those who get SEN support in reference to no support, they have similar unplanned hospitalization rates during primary education using all our methods, as well as similar rates of unauthorized absences when we account for confounding. On the right, when we're comparing EHCP in reference to SEN support, we found good evidence for an elevated rate of unplanned hospital utilization using multiple methods, but also found that most methods for estimation found a lower rate of unauthorized absences. So to get back to the original objective of work package 3 and our third question, which is to explore the opportunities and challenges when applying epidemiological and econometric methods. Well, firstly, we always need to look at the overlap in the propensity for comparison, as some categories of SEN are only comparable in certain populations and not others. Secondly, compared to our reference groups, we consistently found the direction of unadjusted work demonstrating an inferior effect of SEN provision, which is in line with the published literature. However, we can start to disentangle this bias for well-defined outcomes when adding in health data and appropriate methodology to demonstrate it's not always inferior, and in some cases might even demonstrate a protective effect. Our work does have some limitations, as always, such as uncontrolled confounding, and our patient and public engagement groups have suggested that recorded SEN is not always received SEN, as there could always be a delay in putting provision in place for children who have assigned SEN. So here's what we've learned overall, and we'd like to share this with prospective ECHILD users. Firstly, have careful stakeholder-informed derivation of phenotypes and subgroups in HES, since there's no measure of need for SEN in NPD. Secondly, that recorded health conditions are only a singular source of variation of SEN provision and need. There are others that we know of, including social and school factors, and you may know of others beyond that. And thirdly, that causal inference methods, which investigate the impact of SEN provision, can be challenging due to the lack of measures of need, as well as inappropriate measures of actual provision, and perhaps outcomes which might not be too sensitive to SEN provision itself. Our PPI groups often talk about measures which are not captured in our data, such as personal development or happiness or inclusiveness. So, before I let you go, I'd like to invite you all to come back in person to our campus at Bloomsbury on the 4th of April to join our ECHILD User Day. For more information, please join our ECHILD mailing list at ich.echild.ucl.ac.uk. So we thank you all for coming and would like to acknowledge the HOPE group as well as the ECHILD study team, and to note that our results are views of the HOPE study team and not of those of our funders, data providers, or the ONS, who host the trusted research environment which we use to conduct our analysis. Now we open the floor, now we'll go through the questions which were asked. Thank you.
Thank you. Thank you so much, Vincent. And thank you to those who have sent in questions. So some of them have been answered in written responses, so you can see that on the Q&A. We've got a couple of more ones that we could try to answer now. One from Tanisha. I think this is for you, Vincent.
Yep.
Are all of these effects significant? What are the effect sizes?
Hi, that's a really good question. So for unplanned hospital utilization, for certain comparisons, they were not significant. For unauthorized absences, we found a 20% significant reduction using some methods and for some subgroups. So that's what I can tell you for now, based upon the things that we've published so far. I hope that makes some sense, and we look forward to publishing the full results soon.
Thanks very much. And then the next one, and the third one here, I'll ask of you now, Vincent. Why did you use unauthorized absences, as there are illness absences and medical appointment absences? What is the outcome if you use these absences for comparisons?
That's a really good point. So we somewhat struggled when it came to looking at what type of absences there were in the NPD data. So we also looked at total absences, as well as trying to understand what medical absences meant in the data. We found that it was somewhat inconsistently measured between school to school. What we do know is that there are perhaps some government penalties for unauthorized absences. For example, if students miss out school for more than some allotted amount, that their fines start to come in. And what we think is it's quite important that if a child needs SEN, that they should not be punished for missing school based upon a medical need. But yeah, I hope that makes sense. We also did some work on total absences, and we found some similar rates with reduced rates for unauthorized absences. So I hope that makes some sense.
Thank you. So we've got Anonymous, who's got about 3 questions in there. So first of all, there's been a significant rise in SEN, particularly EHCP provision recorded for certain types of need, particularly autism and ADHD. Has there been a similar rise in need for these phenotypes for these types as measured by the health phenotypes? Yes, I think there has been. But we'd need to look at each specific phenotype. But yes, I think it is roughly paralleling what you've been seeing in general. I'm not sure I can follow the second part of this question, but I'll try to answer it. And how do the rates among the pupil population on this phenotype metric correspond to the rate of need by type as identified by SEN provision? So I'll take a shot at this. I think you might be asking what proportion of SEN provision do these phenotypes account for, which is a very good question. Roughly, we haven't published this yet, but roughly these phenotypes, these 3 phenotype groups, so neurodisability, major congenital malformations, and if we add in preterm birth, roughly that comes to about 14% of the whole child population in school, in primary school. And they'd account for something in the high 20s, around 28% of any SEN and around 35% of any EHCP, and just pushing into the mid 40% for any EHCP in special school. And that tells you that there's a lot of other things that are, apart from these rather specific phenotype groups, that are contributing to SEN provision. And as Vincent's been saying, there's social factors and severity factors and the type of school that children are selected into, and then also thresholds of provision within different types of schools are also really important. So healthcare conditions are just one of the factors, and but they're certainly not determining. And so a sort of chase for diagnoses to inform SEN provision really seems not appropriate from what we're seeing from the HOPE study in terms of factors that affect SEN provision. There's many other factors that are important that are not measured in the health data that we have. So what else have we got? So now we've got so this is from Courtney. How consistent is SEN support for these young people? In a set of similar analyses, we found that 70% of kids who need support get it at some point, but only 50% at any one point in time. Really good question. Ayana or Vincent, do you want to answer the question about consistency?
A Vincent question.
I could try.
Vincent, do you want to say something on consistency?
Yeah, so we did what we call an alluvial plot that looks at changes in state transitions between no SEN support and an EHCP from year 1 to year 6. And you are right. Some children lose SEN, some children gain SEN. We find for EHCPs, it tends to be a cumulative incidence, so it just goes up in time. I think what we find was there are really, really good predictors of points in time where SEN changes, and unsurprisingly, they might be EYFSP. They might also be key stage 1, and to some extent, since we didn't look beyond key stage 2 results, we suspect key stage 2 results as well, if that makes any sense. Yeah, I think when it comes to school level provision or school funded provision, what the school has access to is a good predictor of that. There's also other things that vary as well, such as when a school becomes an academy and things like that. So I hope that makes some sense, Courtney.
Thank you. So Brendel's got a great question. Do you have any idea on the time gap between identification of the phenotype and the start or identification of provision? of SEN provision for schools. It's complicated, Brendel. What we've used in using the hospital episode statistics, we've focused on conditions that are there before the exposure period in school, so either before year 1 or before reception, and we've done analyses as well that look at entry into state nursery N1, N2, and what we see there is, so always we're looking at the exposure before the period of SEN provision, the outcome. And what we've found is that neurodisability conditions or conditions that are very obvious in infancy or in the early years, then they are, these chronic conditions are associated with early entry to state school, so N1, N2, and you probably know that almost all of that is, or a very large amount of that is in community or local authority maintained schools rather than academy schools, which tend to have nursery provision less often. So they're associated with entry, so selection into those state nursery schools, N1 and N2, and associated with early SEN provision. So this is something that sort of chimes with our stakeholder engagement as well, where we'll get feedback from them on conditions that are obvious tend to get SEN early on, and which is ideal, and we're seeing it particularly in N2, but also in N1, so that by year 1, about half of the SEN provision that is in year 1 is in children that have received it in N1 or N2. So I think that's a success story that could be increased, but it's less easy to be able to identify the timing of recognition of a health problem in HES. We only see the record when they come into a hospital admission. And so the timing is not that accurate. They may well have been followed up in a community clinic for ages, and then they're admitted to hospital for, respiratory tract infection or whatever. So we have to be aware of that we can't time the phenotype that well in HES. But we've done some work looking at neurodisability types that become apparent in health or education data from year 1 onwards. And yes, there is a group there that then get later SEN provision. So and often quite moderately severe levels as well. So there's a late recognition group as well that might be a late emergence of the problem. Okay, so other questions. Do we know anything about delay in getting SEN support statement? Anyone want to take that?
I could try.
Go on then.
I could try. So that's a very good question. And answering that using the data is somewhat complex, but I can tell you what we try to answer using the data and what we've been told through our colleagues at the University of Cambridge. So in the data, as I said, we're currently using a study that looks at time to SEN and time to EHCP for a group for which we know probably needs it, like children with a recorded cerebral palsy. What we found, I think, and this is soon to be published, so take it with a bit of a grain of salt, since we need to double check the results, is that at the very beginning of when they start school, so either nursery 1, nursery 2, or reception, there is quite a gap based upon certain social demographic characteristics. But then when we move closer and closer towards year 1, that gap closes through time. So that's sort of that. So we also found that those kids who started earlier had higher initial incident rates of incident proportions of SEN. But what we hear from our PPI groups and from the University of Cambridge is that getting an EHCP on paper and getting the provision that is supposed to be part of that EHCP is a different struggle. which unfortunately I don't think we can look at in the data for now. And we are suggesting, improvements to the data to be able to actually look at those things, whether getting an educational healthcare plan from the local authority means getting that implemented quite soon. So I hope that semi-answers your question.
Thank you, Vincent. So we have a great question from Ratan. Thank you for this. Can I ask if you plan to also look at transitions between academic levels, e.g. from primary school to secondary school or sixth form? And I'll just take that question first. So we have, so somebody who's part of the group, Julia Shumway, is looking at this for children with Down syndrome. And she's particularly, so you saw from Ayana's talk, that children with Down syndrome, nearly all get SEN provision, and the vast majority is EHCP. And yes, Julia Shumway is looking at their transitions to secondary school, and particularly to special school or mainstream school. So that's very interesting work that she'll be publishing hopefully soon. But the bottom line is it shows a shift from mainstream school to special school actually right through primary school. And then there's a relatively small proportion that are still in year 6 mainstream school. And she's at the moment looking at what proportion of those go to mainstream versus special secondary school. So it's so watch this space for that. Then your second part of your question is, can I ask how temporally stable these phenotypes seem to be? How may you assess that? Well, really good question. So it's taken a lot of time to develop the neurodisability phenotype that was developed, led by a team by Anja Zilberstein. And Anja's now leading a project that looks at secondary school, again focused on neurodisability phenotypes, and specifically because she needs to reconsider how those phenotypes, neurodisability phenotypes, are captured at that older secondary school age. So particularly looking at mental health related codes in hospital data. So the answer is the manifestations of these underlying problems are of course developmental, and so they change over time. So you're right, it will change, and of course as we want to follow these children into adulthood, we may well see the way they present to hospital data again rather different. So there is a problem that hospital data is relatively crude. We'd love to have primary care data linked into this that would give us much more detailed information, but we're a long way from being able to do that.
I also chip in, if that's
Yeah,
okay.
please do.
So I think for some phenotypes, we do find consistent and a nice gradient when it comes to HES prevalence and incident rates that are somewhat comparable to register data. Cleft lip and palate's pretty nice. You are right, there are some issues there. So when I did my BA Res, we find diabetes is not phenotypically great in HES, and that was probably to do with things such as, the quality outcome framework shifting care into primary care. So we quite carefully look at rates through time, and we try to triangulate those against registry data, whether in the UK or externally as well. So that's one other lesson I think we should put in there. Double check if your phenotype experiences temporal variability in HES.
Yeah. So I think so those of you, I think there's probably quite a lot of researchers on who've used MPD data before, and you'll be very well aware that government policies about service provision affect what is recorded. Well, that's absolutely similar in HES. It's primarily a database that is for costing, and so you'll see coded what is most related to funding formulae. Okay, I think we've got to the end of the written questions, and it's we've got 8 minutes to go. If anyone has any other questions, please put them in quickly. They've been great to have your questions. There are clearly a lot of people working away at this and coming up with very sort of thoughtful, challenging questions. So thank you. And please watch this space and watch the ECHILD website and the HOPE website as publications come out on this area. And we're always happy to get in touch. I think on the last slide, Ayana's put her email in, but you can also email ECHILD and your question will get diverted to us. So thank you very much.
We've got one from Carrie.
Have we got one from Kerry?
Yeah.
Right. No. Kerry says, great work. What do you think politicians will make of these findings? I think that there's so many different answers here. I think one, as I said, with the early recognised problem, children with chronic health conditions going into state nursery provision age 2, age 3, and an increased risk of SEN, receiving SEN. That's a good news story. Early provision of SEN has to be good news, so you're not leaving parents at home struggling with children who sort of increasingly diverge from their peers at playgroup and without support in how to manage them. So there's a good news story. We do see some evidence of delay. I hope what politicians will consider is how valuable this database is for understanding how the system across healthcare, education, and we haven't talked about social care, but social care as well, how valuable this data set is for that, and will push to make it more widely available, but also to think about the gaps that we're highlighting here, where additional data needs to be added in, either as snapshot surveys or from linking in trials or cohorts. So things such as need, let's have a survey that measures need for special educational needs, and let's have some better data collection on what children actually receive, at what intensity and type, and then some self-reported outcomes as we would do in health. There's a lot of audits now that use patient-reported outcomes. Let's start seeing that in schools so that we can understand in a more granular way how this service of special educational needs is, who it's targeting, what they're actually doing, and what it might be impacting. So we've got a great foundation here with ECHILD, but for what you really want to understand about the impact on children and families' lives, it's still relatively crude. I think on that note, it's probably time to finish. Thanks very much for attending. You know where we are, and we look forward to hearing some of your work in future seminars. Goodbye.